Retina Rounds, podcast number 13. Medical innovation is one of the cornerstones of ophthalmology and specifically retina. Today, RetinaRounds is excited to welcome a rising star in medtech innovation, Dr. Frank Brodie. Dr. Brodie is an assistant professor of ophthalmology at the University of California, San Francisco, and an attending vitreoretinal specialist at the San Francisco Veterans Affairs Medical Center. Dr. Brodie has a passion for medical innovation, and in today's podcast, he talks about some of his established, ongoing, and future projects. It's inspirational for anyone who wants to innovate and move the field forward. Let's check it out.
Welcome to Retina Rounds. Welcome back. If it's Sunday, it must be the podcast. We're thrilled today to have Professor Frank Brodie from the University of California, San Francisco joining us. Frank's well known as an innovator in retina and in ophthalmology in general, and a rising star in our field, if not already risen. Frank, welcome to Retina Rounds podcast.
Thanks so much, Steve. This is really a treat to be here, and I'm glad we get to spend this time together. It's been a lot of fun.
Yeah, it's really, really great. Tell us a little bit about your journey into retina, and then we'll talk a little bit about innovation.
Thanks. I had a little bit of a circuitous route, not just to retina, but even to medicine. I was a political philosophy major in college, came from a family of doctors, so as like every good teenager and 20-year-old, swore I would never be involved in what they were doing. Worked in marketing at General Mills and was in charge of fruit roll-up new product development for 3 years, and came up with all sorts of wacky new kinds of fruit roll-ups. And the one that made to market was the tongue tattoos one, where the kids could lick it and they'd end up with a tattoo on their tongue. I was involved in that kind of nominally, and some other products that never made it to market. Looked around, realized I didn't want my boss's job, and that I didn't want my tombstone to say he made fruit roll-ups and gave kids cavities. So then I looked at my parents and saw how happy they were in medicine and how rewarding they found it. So pivoted and went back to undergrad for another year, did a post-bac, took all the science classes I'd never taken, and got into medical school at University of Pennsylvania. Missed some of the business stuff, though. I really liked working in teams of people who had different specialties and were figuring out problems and kind of tackling some of those business problems head on. And so I had this great opportunity where I could go to Wharton Business School while I was at Penn and spend some time there and get an MBA concurrent with my MD. And it was that time I started kind of exploring ophthalmology. You know, I come from a family of ophthalmologists, in fact, retina specialists, both my grandfather and uncle. And they said, go into whatever you want, but at least do an elective in ophthalmology to see if it's something that appeals to you.
And where were they based? Where were they? Where did they practice?
They were at UCSF. So I've really, I'm third generation UCSF retina to get to the punchline of the story. But I was with Sandy Brucker at Penn, did my rotation with him, and he is just a wonderful guy, wonderful doctor, and really took me under his wing. And it's just been a terrific mentor to me even now, and really turned me on to the whole field beyond kind of all my family stuff. And
Sandy is a mentor to all of us.
Yes, true.
He's not only a giant in our field and made huge contributions editing the journal Retina, and his academic work has been nothing short of amazing and very impactful and innovative, but he's just a sweetheart of a guy. He's so kind and so caring, and I love him because he's old school, and I also love him because he has a great sense of humor. But he has really a great perspective and very valued mentor. So you're very lucky to have interacted with Sandy. Sorry for interrupting. Carry on.
No. I agree 100% with everything. And the interest and warmth he showed me, you know, taking me to meetings with him, and I was just a nobody medical student. So it made a big impression on me, and I really valued his mentorship. Got deeply involved in ophthalmology there at Shea. And then came out, did an internship at Harbor UCLA, where I got to meet Dr. Prasad, and that was wonderful. We interacted a little bit there and got my first taste of that LA life. Loved it. Came up to UCSF for residency, and by then I was really hooked into retina, you know, and just having exposure to it. And I remember actually seeing my first RD even back at Shea, looking through the scope, seeing this beautiful 3D landscape of retina flying everywhere. I said, this is the coolest thing going. There's nothing else like this.
Kind of looks like a fruit roll, doesn't it?
Yeah, exactly. It was very similar. And yeah, so they had some blue in the eye, and, you know, I felt right at home, you know. And so I finished the residency at UC, and I've been fortunate. I'd gotten involved in some kind of more creative projects along the way, doing some of my research, where we were looking at new technologies. You know, my uncle Dan Schwartz is obviously a very creative guy, very innovative. Has probably his most notable thing is Calhoun Vision, which then became RX Sight. But even before that, he was involved in OCT angiography. A lot of the early efforts, I don't think he gets enough credit for it, was in OCT angiography with Scott Fraser down at Caltech and USC. And they actually were the first on the cover of Retina, the very first cover of Retina talking about OCT angiography was their paper showing that it could be done with phase contrast. It was a slightly different approach than what's commercialized now. And so we looked at an OCTA project where we are going to put it in all the Walgreens across the country, and diabetics could get screened. And we, kind of built a company around that idea, and had a lot of unsuccessful efforts in innovation in ophthalmology. But it really got me hooked into the idea. And so when Mark Blumenkrantz started an innovation program at Stanford, kind of while I was in residency, they had this what's called an ophthalmic innovation fellowship, and you would spend a year with Mark and Dave Myung, who's a cornea guy there, is a wonderful guy, interacting with them and taking advantage of the Stanford campus, learning through their biodesign program, which is a kind of a university-wide program at Stanford, looking at biodesign more generally, not just ophthalmology. Get to be involved in that, and then also spend time at the FDA. And I got to spend some time with Malvina Edelman at the FDA and the folks there, really learning about regulatory science, and seeing kind of behind the curtains how those decisions are made. So elected to do that. It's been a wonderful year. Did a lot of pretty interesting work on several programs, and got to work very closely with Daniel Palanker. I realized I'd never kind of been in a lab in the traditional sense, so just kind of cold called Daniel Palanker, who has done a ton of things in ophthalmology, Pascal laser and numerous others, and said, "Hey, Daniel, I'd love to be in a lab and work with animals." And he said, "Sure." And so I got a lot of experience there. I'm happy to talk kind of at length about my time there because it was really formative. Wound my way over to Duke for fellowship, which was equally great. I think I've just been so fortunate in my training to be around some of the really big folks who've had such an impact on the field and impact on me. And then now back to UC for attending life. So a very long and kind of twisty answer to what was a pretty simple question by you.
Well, no, it's really important because a lot of our listeners are training, and some of our listeners are considering retina, and all of our listeners are considering their path, even if they're already established. People who podcast are explorers, and their minds are open, and so it's really nice to hear your story and to synthesize it. You incredible institutions, incredible curiosity, a drive for something new all the time, but probably most importantly are the mentors.
Yeah.
If you work backwards from forgetting about who you're working with now at UC, you've got at Duke, Glenn Jaffe and the team at Duke, all Cindy Toth, amazing, amazing people. And then Mark Blumenkrantz, Daniel Palanker, David Myung, the whole gang at Stanford. Tom Crummell runs biodesign or ran biodesign, I think, when you were there. It's just an incredible program. And Penn with Sandy, remarkable, remarkable. Frank, I remember from the time you were visiting us as a medical student, I believe, maybe as a resident, you were working on a really touching project, putting glasses on kids with facial abnormalities.
Yes.
Tell us a little bit about that story. I found that very moving.
Thanks, Steve. Yeah, and it's something we're continuing to work on, and we've got a lot of great partnerships. So this is actually born out of a residence day project. And at UC, we have the second year residents and third year residents do a research project. And the second year, we give them like 8 weeks off. And in the third year, you're just expected to do it. And you can kind of do anything you want as long as it's got some scientific rigor behind it. And I now mentor a lot of these projects. And what I push the students to do is I say, don't just do another chart review unless it's a really interesting question. Don't just do another chart review. Now is your opportunity to try something and fail and do something crazy and do something wild, because later on in life, you either won't have the bandwidth, or if you're in academics, you're going to have to get grants, and those can't always be quite as exotic. So do something crazy while you're a resident. Do something far out there. And so this was born out of one of my residence day projects. When I was rotating in pediatric ophthalmology, we had a young girl, a 3-year-old girl, who had a craniofacial malformation. She had craniosynostosis. She had already lost one eye, and she had this other eye that they had done all these kind of heroic glaucoma surgeries and all this stuff on. It was actually anatomically doing okay, but she was losing vision due to amblyopia because she could not keep glasses on her face because she had this craniosynostotic head and just couldn't accommodate glasses. She had about 3 different straps she was wearing, and she was miserable, and she would scream and throw them off. And anyone with kids knows you can't just reason with a 3-year-old. It's not a viable approach.
Sort of like a retina fellow.
Yeah, exactly, including the screaming and throwing things off.
I'm kidding. But what I was going to ask is, and forgive me for being so naive, but can you get amblyopia? I guess you can get a refractive amblyopia even if you're monocular.
Yeah, and she had a very high refractive error. I forget what it was, but in these kids, in this craniocytostotic population, there's such a much higher level of amblyogenic refractive errors. It's about 1 in 5 will have an amblyogenic level refractive error. I assume because of changes in the orbit, kind of pushing the eye formation one way or another. But I'm not smart enough to figure all that out. But it is known that they have much higher levels of refractive amblyopia.
So how did you solve the problem?
So I had this idea about 3D printing, and it wasn't as mainstream as it is now. And people say, "Oh, 3D printing." And listen, my kid has a 3D printer, but we said, "Why can't we make a custom pair of glasses for this little girl?" And she'd recently had an ENT surgery, so she had a head CT. And I just walked into the radiology office and I said, "Hey, can we create a model of her head so then I can build some glasses for it, in 3D space, print them out?" And they were able to do that at UC. And so then I did that, and then I just started cold calling glass designers because within about 3 minutes of me screwing with the glasses design program, trying to do something on these computer programs, I realized I have no business doing this. I couldn't even get 2 lines to meet. And so I went on LinkedIn and did Glass Designer San Francisco and just kind of went down the list and called every single one of them until one guy said, "Oh yeah, it sounds like a worthy project. Send me over the 3D head model, and we'll build a pair of glasses for this girl." And they did that. We were able to 3D print them out at the library. They had 3D printers there. And it worked out, and she was able to wear this pair of glasses, and I think she's on her 4th or 5th now as she's continued to grow, and it's really changed her life. It's prevented vision loss in a meaningful way.
Spectacular. Tell us about the project, though. What's going on now with the overall effort?
Yeah, so we've expanded it, and I was really after we'd done a couple kids like this, we realized, hey, this really has legs. We were able to raise some money, and the guy that really helped spearhead this was Andy Corley. He's been in the industry for a long time. He's been involved in a lot of exciting things, including he's chairman of the board of RxSight. And he was a big believer early on, gave the first kind of tranche of cash and introduced us to all these people across industry who've really generously supported the project. So we've been supported by Allergan, Bausch and Lomb, Genentech, you name it, has really stepped up. Our industry has really stepped up. We're in, I think, 17 different hospitals now: Boston Children's, Duke, Stanford, UC, Kaiser, Minnesota. I could keep going on. I think we've got about 50 doctors signed up, and we've helped about 75 kids with many more in the queue. So I encourage all the listeners, please check it out. It's lovingeyesfoundation.org or lovingeyes.org. Both websites work, and you can see photos of these kids, figure out how you can get involved. If you have a patient you want to refer to us that you feel like has a unique anatomy that can't be currently served with glasses, send it our way, and we're happy to help out. Everything's free of cost, obviously, to the kids, to the families. It's all supported by donations, and if you're on that website and feel so inclined, you can also donate.
Oh, you're so kind. Well, it's wonderful to have the privilege of having something work when you're so early in your career. And by work, I mean have an impact and see it really, some creativity positively change a patient's outcome and then apply it to more patients. And I'm sure that had a lot to do with you having an incurable disease, meaning you have to innovate all the time. You can't help but tinker. And so let's jump ahead to what can you tell us about what you presented at the veil vitrectomy meeting this year, the artificial capsule. If it's too red hot to talk about, we can change the subject and cut this out. But if you can talk about it and share, we would love to hear it.
Sure. I think I can talk about some stuff and you decide what you want to cut out. So one of the things, and just to make this hopefully a little bit more actionable to the listeners, especially the junior listeners, I do have some thoughts. One is that when you're in training, you have this opportunity to see things, what works and what doesn't work. And I think you get to see it with pretty fresh eyes. At some point in your career, you say, well, that's just the way things are, and that's just hard, or that's just easy, and we just kind of accept it and we move on. I think when you're in training, you ask the question why a lot more. And why do we accept this? Why isn't this done better? Why do all our solutions suck? And, as I went through training, I was exposed to all these cases where there was insufficient capsular support and people were jury rigging the lenses, right? They were doing Yamane technique, they were doing scleral suture, they were doing some iris sutured lenses.
Let's just
And
stop right there because that has become, to my great unhappiness, one of the favorite things that retina fellows want to do. They want to get in that pasta bowl and have sutures coming out of every port known to man and sew
it's
these.
misery. It's misery.
It's beyond misery, and it's really, in my opinion, often not as good as a well-placed ACIOL.
Yeah.
But there are cases for it, particularly in certain circumstances. And it is a surgery that does extremely well, and people are very happy with it. So I don't want to denigrate the surgical approach. So you're faced with this problem. How did you solve it, or what did you do?
So I always, I kind of like to see how nature solved it, right? How do we have an eye normally supporting our lens, and it's through a capsule? And so we had the idea is can we generate an artificial capsule? And this is where the beauty of that Stanford year was, because it really gave me the bandwidth to experiment and try and explore. And going back to the 3D printer, I was able to kind of work with a really smart guy who just finished undergrad there, who knew how to do 3D printing and design. And we started drumming up all these kind of different designs for what an artificial capsule would look like. I had the idea, I had the clinical limitations, a clinical spec in my mind of what it had to do, what it had to accomplish, what kind of lens it had to hold, where it had to fasten in the eye, how stable it had to be. And I think with that clinical perspective, we were able to collaborate. He was more of an engineering type and drum up 18 zillion different designs. And the cool thing about ophthalmology is we have such a great model in the ex vivo pig eye. It's the anatomy is not perfect, but you can really try a lot and figure stuff out. And so for about 9 months at Stanford, we'd tinker around in the morning, 3D print out the designs over lunch, get into the pig lab in the afternoon, play around till supper, and then we'd go back, change the designs, and the next day just rinse, wash, repeat for about 6 months. We were figuring out different anchor types, how the capsule would attach to the sclera, what worked, what didn't, how it would hold a lens. We'd poke and push on the lens to see if it would pop out. So it was just a really great time to do science in a pretty unstructured way. I wasn't stuck to a rigorous protocol or trying to apply for a grant or worried about p-values. I was just trying to solve the problem with this other guy, Dave Buchtins. And it was great. We came up with a lot of really interesting designs, and Stanford ended up patenting some of the work we did. And a company ended up picking it up and has done some outside the US clinical trials, and that's what I presented at Veil Vitrectomy. And it's been really exciting to kind of see that evolve from a clinical observation to just tinkering around to hopefully what's going to make its way into more and more patients in the future.
And so the clinical trials videos were stunningly good, stunningly good. And I'm a big time skeptic. I was particularly struck by the elegance and simplicity, the wide visual axis, and the stability. And I was also struck with how easy it was to put in. Really a game changer. I think I mentioned to you, I would like a version of it made out of a different material at some point for eyes so that it can accommodate different tamponades in the long run. But without giving away too much, it is really a game changer in my opinion. And I hope, and I don't know, I hope whoever took it brings it forward because the business proposition is probably reasonable, but the patient care proposition is enormous. It's really going to be impactful. And
That's so nice. Thanks, Steve.
well, I feel that's really important. That brings me back to another mentor. We've had Steve Charles on, one of the great innovators in retina. We've had Mark Blumenkrantz on, one of the great innovators in retina. We've had some other people on that are giants in other areas. But one person we haven't had on, because Uday had him on Cataract Coach, our sister podcast, is Jean Dewan. And I know you and Jean are close. And tell me how interacting with Jean has helped shape you.
Jean has been just a fantastic mentor, starting early on in residency and all the way to today. We're very close, and especially on this capsule project, he's obviously been very, very closely involved and wonderful. Jean is infinitely creative. you look at a problem and you kind of have these implicit boundaries in your mind, and he doesn't have them. He can approach it from every which way. He can turn it upside down, and he'll ask questions. He doesn't just say, "Oh, why aren't you doing? Why aren't you?" He said, but why aren't we doing this? Why can't we? And his way of kind of Socratic reasoning and approach and working with the team is, I haven't seen anything like it. It's really eye-opening, and it helps bring everyone to better solutions. It's not just directive. Um, on top of that, you can't find a nicer guy.
Or
He's
more
just so
fun.
warm. What or more fun? He's a very fun guy.
Yeah,
Um, but he's a total pleasure to be around, and he's just not a top-down kind of guy. He's really a team player in the trenches with us as we solve through problems. And sorry, there's the golden retriever barking.
that's okay.
Um,
Listen, I'll tell you a Gene Dewan story.
please.
I was very lucky to work with Gene and Mark Humayun. The three of us were working for Bausch and Lomb years ago on the first 25 gauge system. Mark and Gene had innovated it, and for some reason, probably still unknown, Bausch and Lomb asked me to join that team. And I remember being with Gene and Mark at a number of meetings, and we were in, I think, St. Louis. I can't remember where we were. And I remember Gene saying, this is great. We're talking about the how we were going to put the trocars in and the cannulas and so on. And Gene said, you know what I really want to do is this thought about having a porthole in the eye that we can just put things through at any time, not just during surgery. And it was the genesis of the port delivery system. And
Wow.
he had this idea. I watched him have the idea, and this was a good 25 years ago, 20, 25 at least years ago now. Yeah, time flies. And he held on to that idea. He iterated it and iterated it, and it became the port delivery system, which is essentially ocular, like a window on the side of a ship through which you can deliver drugs and access the inside of the eye. And what a giant innovation. But just to watch the process and watch it grow in his mind and watch him solve, a real treat, and a treat for our patients too, because he's changed our field. So for you to be next to him doing this is a real takeaway for our listeners, because it's quite important to keep the right company if you can, and to learn from them.
You
And
know, it,
go
it,
ahead.
just to interrupt you here is it reminds me of some advice Marco Zarbin gave me a long time ago. Marco Zarbin is kind of a family friend through my Uncle Dan, and I've known him, since I was a little kid. And when I was trying to figure out where to go to medical school, I was looking at some good medical schools, and also possibly going into Penn, which I consider, a great medical school. But the logistics of going in from my post-bac to the other medical schools was much easier. I didn't have to take the MCAT and could kind of do all the stuff, versus the road to Penn was more challenging and more expensive. And so I called up Marco. I said, Marco, what do I do? Aren't all these medical schools the same? Didn't they standardize all these medical schools? Why would I, deal with all this hassle with Penn if I can go to these other places much more simply? And Marco brought up this concept of propinquity, and I had no idea what that word meant, and I promptly looked it up. But basically, the idea is you get smarter by being around really smart people. And I think you can expand it to good mentors. And I think I've been really fortunate to be around smart people and good mentors. And I think it's helped me tremendously and made my work better. But I've also really sought it out. And I think that's important for the listeners, especially, more junior folks, is try to be around people that are doing great things. See how they do it. Be inspired by them. Get to know them. I think it's been tremendously helpful for me, in any progress I've made in my life, is to have these wonderful mentors in my life that I've sought out. And, you kind of find luck when you're around people like that,
I
I don't know.
want I just want to say to Marco, if you're listening, it's not the only reason we hang out with you. We also like you. But you do make us better. Uh,
We'll send him the episode. We'll make sure he listens.
he's an upcoming guest. So
There we go.
we do grow tremendously, being around those people. Let's talk about the genesis of innovation. So you're a professor in the ophthalmology department at one of the great departments in the world at UCSF. great leadership. You've transitioned from Steve McLeod to Jackie Duncan, and you've got a great set of colleagues in retina and a great set of colleagues across all the subspecialties and a great community. You're at the northern edge of Silicon Valley, the innovation hub of our world. And so talk to me about the spark, Frank. What's that moment for you? Is it clinically looking at a patient that has a problem? Yeah, I know you've been really immersed in the artificial capsule, but I also know that you have 5 ideas a day, and even if 4 of them are bad, that's 5 more than most of us have. So talk to us about the spark, the genesis of the spark.
So I think as clinicians, it is rooted in clinical need. And I think it can be, however we define clinical need, it can be like a big, important problem that is really well identified, myopia, RP. These are big things that everyone's talking about, and there's a lot of innovation. It's important. GA, right? There's obviously a clinical need there for all these things. But I think it could also be things that are less obvious, where we just find the standard unacceptable. We talked about getting glasses on kids with abnormal faces. Another one is I think scleral depression is unacceptable. I think the idea that we have to go around and mash on the side of the eye just to get a view to maybe see if there's a break is ridiculous in this day and age. My grandfather trained with Scapins and brought over indirect ophthalmoscopy, 50 plus years ago to the Bay Area. And
Hit
the
me
idea
again. Hit me again. More than 50.
more than 50.
It was.
How far was it? 70 years in the 1950s when he
Well, it's 2025. So 1970 was 75 years, long time ago, 50 years ago.
50 years ago.
It's like 75 years ago. Aria, you're talking about Aria, right? So
Yeah,
that was a long time ago.
yeah, exactly. So in any case, it was a long time ago. And the idea that I am examining the peripheral retina in the same way that he did it, the way he learned from Scapins, and finding breaks in the same way is ridiculous, And we thought that Optos, and I apologize to the Optos guys if you're listening, but we thought this was going to be a godsend, and we were going to find all these breaks, and we're just going to look on pictures, and it turns out that's really not a good way to do it. A zillion studies have shown that you don't detect that many breaks if you just get an Optos, right?
I'm not offended.
And then we thought
I'm not
Optos.
offended, Frank.
Okay. And then Optos OCT is great, but it only works if you know where the breaks are, and you can put that
So
little,
what's your
cube
solution?
over there. So I worked with Cindy over at Duke and developed a peripheral OCT machine that can do 360 degrees of OCT, kind of a donut, with the idea being it from equator to aura. And you just put a little contact lens on the eye and can get this donut of OCT that you scroll through and see if there's a break. And if it's there, you have the anatomy, you have a record, all the things. And we're not done with that project. We're still working through it. We're
Well,
fortunate to get an
great minds,
R21 grant.
great minds think alike. We've been working on a non-contact peripheral OCT at UCLA for years with the optical physicists, and it's a great project. And probably we should combine them. This is one of the guys who helped fix the Hubble Space Telescope, and it's basically the same thing without the contact lens.
I think I'm just happy for someone to succeede.
I don't know if we're going to succeed or not, but the idea is to have an EKG strip by clock hour.
Exactly.
Just read it out and see.
Yeah.
And it needs to be. It needs to happen. Although I will say, Arya did not mash on the eye. His scleral depression was very gentle.
It's like a feather.
Like a feather, didn't hurt. And I'm sure you have this all the time when your patients say, "How come when you scleral depress my eye, it doesn't hurt, but the fellow, anyway, it's
never with my fellows. Never. I don't know what you're talking about.
Yeah, I'm talking about my fellows. And I'm kidding, of course, my fellows are awesome, but the point is, scleral depression is an art, and it's a really great thing. So here you found a very common denominator, a very common issue that we face patient by patient.
Yeah, but going back to your original question, I think it's that. I think it's first you identify a need and dig into it, And as Gene says, Gene's thing is when I bring him new ideas or things, he says everything is interesting. We got to find the things that are important. So I do think that's true. I think, and the residents will bring a lot of things to me that are interesting questions or interesting product ideas. but they have to be important. It has to be worth all of our time, right? There's 8 zillion things we can do in a day, and if we're going to dig in and really do something well, it should be important.
Well, that's
Um,
an interesting argument. We have that a lot, especially in basic science. Should the research be directed, or should the basic scientists have freedom to operate and just chase what interests them? Because who knows what's going to turn out to be relevant. If you're solving a mechanical clinical issue, concrete clinical issue like scleral depression or absence of a capsule, yes, I think Gene's comment is germane, but we're not all Gene Dewan. It's hard to sit there and rule on what's important and what isn't, what's going to end up having relevance and what isn't. You think about PCR and the advent of different techniques that were completely peripheral to anything meaningful when they were developed, and then all of a sudden they become very mainstream because they've got a mainstream application. So Gene is right. It's important to uh, to spend your time wisely. Uh, Mark Blumenkrantz always says to me, uh, it's equally hard to cure a small disease as a big disease. And so, there's nothing wrong with innovating around a microorphan. People are suffering, and but looking at major public health issues maybe is more important. I'm not the judge, but it's a very interesting topic to hit on.
yeah, and I think important doesn't necessarily mean big, right? I think important, like you said, it's if there are some people suffering and deeply suffering and they have nothing, just like the Glasses Project. That's not a lot of kids we're talking about, but there's nothing for them, and so I think it's important and worth our time.
And what a giant, not a huge, no downside to that, right? That's the beauty of that. That's just kindness and smarts equals profound impact. There's not a giant spend there. There's no risk to those patients. They're just putting glasses on. It's amazing.
Yeah, thanks.
It's just amazing. Tell us about the clinical programs at UCSF. What's the Tell us about what's the program like in retina right now, particularly around the fellowship. It's a great fellowship, and I want the listeners to hear about it.
Well, it's an exciting time for UCSF Retina because we really have recently expanded. We have Luciano Custa Gregg joined our faculty. He was a USC fellow and is now up here on faculty doing really exciting stuff scientifically and has built out a beautiful clinical practice. Um, there are four of us that do kind of bread and butter VR, myself, Jay Stewart, Bob Bissicle, and Luciano. We have Jackie Duncan, who does inherited retinal disease. We have Armin Afshar, who's dual VR trained in tumor. And then we have the Proctor Institute, which does posterior uveitis, with Nisha Acharya and John Gonzalez. So it's a great place to practice because I have so many colleagues in all these different specialties. And they're not just kind of dabbling in them, they're deeply and I really know the specialty well, really educate me. Anytime I bring Armin, a possible tumor, or I bring a uveitis to Nisha, I'm listening, I'm reading their notes, I'm digging in, I'm learning, I'm Googling, how do they think about this? How do they manage it? Because I'm fortunate to be surrounded by so many excellent subspecialists. The other really cool thing about UCSF, and I'll just make my fellowship pitch, is our practice settings. We've got much like where, UCLA, Steve, is where you have your university hospital, right? Where you kind of get the ivory tower stuff and people coming from far and wide and other countries to get care, as well as patients that are just kind of plugged into the university system. But you do get some very interesting kind of third opinion patients. But we also have our county hospital, right? We have San Francisco General Hospital, where we take care of the indigent San Francisco population and uninsured population.
They still have that in San Francisco?
We have a few, it's mostly tech millionaires, but we still have a few people. Uh, and then we also have the VA, where I spend most of my time. And, taking care of the vets is really a privilege. I really enjoy caring for that population, and they have interesting pathology, and it's just a great population to be taken care of and a great system to work in. And so our fellows get the experience of all those on top of kind of this diversity of faculty. So I love practicing at UC. I was here for training and here on faculty and don't see leaving because it's really a treat. And then on top of that, you get to layer in all the innovation stuff. Like you said, we're in the north side of Silicon Valley, and the ecosystem here, especially around the life sciences with Chan Zuckerberg BioHub and all these other kind of exciting institutes, really makes it a lot of fun. And the stuff that comes across your desk and the people you get to collaborate with, is very exciting.
Fantastic. And is it one fellow a year or two fellows a year?
So we were one fellow every other year, where we would basically keep one person for 2 years and get a new person. This is our first year. Now we're going to go to one fellow every year. We realized we were so clinically busy. We had so many cases that weren't being covered at all by the fellow. We just thought there was a real lost opportunity. Plus, it'll allow the new fellows now to spend a lot more time with Jackie and Nisha and Armin and get into the subspecialties. So I think it'll actually expand our offerings rather than kind of crunch it down because of
Oh,
how.
it's going to be much better for the fellows because remember, fellowship means fellowship. So they could be actually with somebody, which is great.
Right.
And that's one of the best parts of training programs is the friends you make that are at your same career stage. I'm sure you think back, and I know a lot of our listeners do. I do, and it's lifelong bonds to walk over the coals together. The opportunity to have what I call the high-low mix, to have the mothership at UCSF in that beautiful environment, and couple that with the VA, the county, and Proctor is such a gift. And for those of you who don't know, UCSF produces some of the very, very best residency product, meaning everybody who goes into top residencies and almost any ophthalmology residency in the country or the world are smart. But there's something about UCSF culture that has maintained through Steve and now Jackie, and it's kudos to the faculty and the environment. People come out with a maturity and a sense of responsibility and perspective that is relatively unique. You produce great ophthalmologists there. And the Retina Fellowship is the same. And so it's really great. I'm thrilled to hear that you're expanding it. And what I'm also thrilled to hear about, and I think our listeners who are thinking about fellowship should be considering, is Frank Brodie's you're attending at the VA. That's amazing. That's supervised uh, innovator supreme at the VA with you, taking care of your puckers, holes, detachments, drop lenses, and endophthalmitis cases. So you're learning how to deal with things from a master, and they're driving. I'm imagining at most of these cases particularly out at the outside hospitals. Is that correct?
Yeah,
A lot of supervised autonomy.
exactly. Yeah. Yeah.
So their caseload is high.
Yeah. They're very busy fellows, and it's good. But we make a point as there is an attending with them. I think there's always that balance, right? And I think every program does it a little bit differently because the fellow needs to graduate with some level of autonomy, right? They need to learn how to function in OR without a ton of hands-on direct supervision. But at the same time, you want to teach and impart as much as you can during those fast 2 years. And so I think, Steve, you're obviously a master at this, right? You graduate, the top fellows in the country every year. And so you have taught them both all the things they need to know to function as a retina doctor, but at the same time, they get that sense of autonomy. So I need to, at some point, pick your brain, either now or later. I'd love to hear what you have to say about it, about how
Well,
you balance those.
it's a high-low mix, and it's very dependent on the fellow. For years at Jules Stein, we would, by chance, take a fellow from a marquee program, so Duke or UCSF or UCLA or Harvard or wherever we were taking the fellow from, and then we would take at Bascom. So we were taking someone from a program where we knew their training was rigorous, where we knew they had great experience in VR already, where they had already done hundreds of surgeries and they were great. And then we would take a fellow from a mid-tier program that was more of an unknown reputationally to us. Doesn't mean the quality wasn't there, but the person was outstanding. And what would happen is almost invariably, the marquee fellow would start out with a big advantage. The internal candidate or the Bascom or the UCLA would start out, but then after some training, they would get lapped by this other person, and then they would be neck and neck like a horse race. We would watch it happen. In the end, they turn out to be both amazing, which is really we were really proud of. But it's a very individual process. You've got to philosophically have a strong culture to lean on, and make sure that your fellows are not counting cases, but really focused on the person beneath the drape and the privilege of caring for patients and reducing suffering and doing what's best for them, not what's best for their training. And if you're lucky, when you interview, I always said that getting an interview, table stakes, everybody's smart. Everybody has a great CV. You're looking for people ask me all the time, what are they looking for at my interview? Well, first of all, um, trying to figure out whether or not you're a psychopath and, and figure out whether or not you're patient first, what your motivations are, who you are as a person. The fellow candidates who come in with canned answers that are basically reading to me from ChatGPT, I have no interest in.
Yeah.
It's the people who are authentic, who open up. Um, and I'm sure that's the case at UCSF too, because you guys just develop incredible surgeons. What's the transition been like from Steve McLeod, the current CEO of the American Academy of Ophthalmology, to Jackie Duncan, probably the nicest, smartest inherited retinal disease expert in the world, who
Yeah.
I've had the privilege of working with Jackie over the decades, and I've learned so much from her. And to me, she seems like she would be a dream chair, but what's it like?
No, and to echo the first thing you said is she is both the nicest and the smartest and the most patient-centric person I've ever met. You know, you'll be in a busy clinic and you'll have the patients bring you the forms and the this and the that, and you say, yes, and I'll get to it at the end. I'm busy. She'll get those forms done so the patient doesn't have to come back, doesn't have to wait for the fax. She will go the extra mile. She'll call who needs to be called. She'll be on the phone with a relative. She, despite her, 8 zillion different responsibilities for Foundation for Fighting Blindness and everything, she is, at the end of the day, the most patient-centric person I've ever met, and cares so deeply for those patients. And she takes care of sick patients with, RP and all these inherited retinal degenerations that are really having a tough time. And I think
Yeah.
it would,
Five cones left.
yeah. And I think it would be so easy to get jaded or get burned out. And she, I've known Jackie for a long time, having done training here and still be on faculty with her. She has not lost one iota of that compassion and that drive for patients. And above all else, that's earns my undying respect. On the chair front, it's been incredible. Steve McLeod was just a fantastic leader. Really made these huge strides at the university where we built a whole new eye center and really managed all these external forces coming down on us in a masterful way. And when we transitioned to Jackie, we said, "Oh boy, this is going to be a transition," and she did not lose one step. We powered through COVID, got the eye center up and running, is recruiting faculty like gangbusters. Getting more patients through, improving efficiency, decreasing all this in basket. And her mission is to have us doing less and less non-physician tasks, I think is the jargon or whatever it is, right? In box, all this other crap. She has massively done that. I mean, she fights for the faculty. And that's kind of, listen, I think everyone has different metrics for chairs, right? It's if you're the dean, you have one metric for the chair. If you're faculty, you have another. If you're a student, you have another. My metric for chairs is how much they fight for the faculty against the outside world. And she does it with her dying breath. You're getting emails from Jackie at 4 in the morning saying, "Okay, I followed up on this. I've nominated you for that, or I'm doing this," or it's incredible. I mean, her tenacity and her energy and the way she's approached the chair job is, I can't imagine seeing it in many other people.
And she's highly accessible, right? You can walk
Oh,
into her office anytime.
text her any like
She answers, she's there.
she's not in some ivory tower. She's not on the hill. She's, every bit as warm, with her faculty as the patients, and it's incredible. A plus.
Yeah, that's very fortunate. She is masterful. Well, it's a luxurious academic environment, and it is like all the UCs, ophthalmic heaven.
Yeah.
So I'm super happy for you on that front. So Frank, Brodie, what's next for you? What are you predicting? Maybe not for you innovation wise, but what do you see as the next really big step forward for retina?
I'm very optimistic about gene therapies and restorative therapies in retina. I think that we are kind of at an inflection point now where we're going to see better delivery vehicles. We're going to see us being able to, in my kind of high level view, and I'm not an expert in this stuff, and you really are. So please, push back if you think I'm off base here. And I think a lot of the readers know, or listeners rather, know a lot more about this than me. But it seems like we've really encountered a lot of issues in the past with kind of getting gene therapy in there, inflammation, problems with atrophy and scarring, this kind of stuff. But my sense is that we are at a precipice where that's going to become less of an issue. And we're going to be able to deliver gene therapy and optogenetics and all these restorative therapies in a much more efficient, safe way that's going to open up a world there. Um, The other side is I've been working on a retinal prosthesis project here. It was kind of a full circle story where it was something I'd actually worked with Daniel Palanker during that postdoc year, became a company called Pixium. It's a subretinal implant. He went to a French company, and then just got bought back by a US company based here in the Bay Area. And I've been helping with that and involved with that process. And this idea of using a photovoltaic implant, or I think there's other folks doing similar things out there that can really restore vision to blind retina, is incredible. And we're certainly, listen, we're at V1 on this stuff. We're at the Macugen level, but it's not hard to picture in the future. And I've been fortunate to see some of the R&D going on behind it, where really we will be able to restore vision to areas of retina that just had no sensitivity at all, could not see a thing. And now the patients can have formed, clean reading, crossword puzzle kind of vision. And some of these videos are out there on YouTube where you can see it, really regaining meaningful vision back. So that's very exciting. Everyone's hopeful, obviously, in GA that pharmacotherapy is going to, prevent this kind of vision loss, and I'm hopeful we'll get there. I think those are the big things that are exciting me. I think surgically, we're going to get more and more sophistication of our tools. I think we're getting our tool set now is kind of faster and faster horse-drawn carriages. But if you look at kind of the things that are happening in fields like orthopedics, where they have, real-time imaging informed surgery, where, if you get too close to the wrong place with your bone saw, the saw shuts off and it kind of forces you into doing a certain type of pattern in the bone and things like that. You can imagine that being, drawn down in a retina where you only can grab the ILM. Your forceps do not work if you're too deep, things like that.
It's Horizon Surgical. I mean, that's
Yeah.
what JP has got going
Right.
on. And the first application, of course, is cataract surgery, but certainly in the lab, the no-fly zone and the detection of epiretinal versus retinal tissue is there in the forceps already. And
The
it's
future is now.
it's coming. Yeah, it's coming. And people think, well, it's going to replace me, but it's exactly wrong. It's you want to get on a 747 that's got autopilot and a pilot. You're not replacing. It's surgeon plus. It's not surgeon instead. And so it's really, that is a really interesting area. Well, Frank, it has been a pleasure to chat with you this morning on Retina Rounds, and thank you very much for joining us. Your work is inspirational, and your career arc is magnificent, and it's not a surprise that you're V3. I never thought anybody could be more innovative than your Uncle Dan, who I love, but you're there. And I think it makes him smile to know that.
Well,
And
thank you so much, Steve. This has been such a treat. It's been so fun chatting with you. And just to let you know, when we did my son's bris, I said there's something that sounds nice about fourth generation retina specialists. So,
that's good.
in a cool 30 years, he'll be there.
That's right. Well, unless you end the field by curing everybody. So, Frank, thank you very, very much for taking the time with us here on Retina Rounds. I'm going to encourage all of our listeners to reach out to Frank Brodie at UCSF. Frank is incredibly hospitable, fun to be around, loves to meet people. And if you're an innovator out there on planet Earth and are looking for somebody to work with, reach out to Frank. He'll guide you or invite you. And if you're in San Francisco, he'd love to show you around. So thanks very much, Frank, for taking the time on Retina Rounds.
Thank you so much, Steve. I really appreciate it. This has been a total treat.
If you enjoyed this video, please visit us at RetinaRounds.com. There you can sign up for our email list. You'll get a notification every time a new video is posted. And if you have an interesting video or a tip or trick that you'd like to share, please follow the links on our website and you can upload your video there. Thanks so much for watching.